Hi, and welcome back to the MD, PhD, ETC lecture series on the Introduction to Psychiatry. I'm going to do a little bit of an addendum here in terms of the actual practicality of how to prescribe various antipsychotics based on the previous lecture, which was sort of more generalities used for a lot of different disciplines. So this is specifically for people who are prescribing. Standard disclaimers that, always consult your physician desk reference, always look for the latest FDA bulletins in terms of warnings, always correlate clinically in that regard. But I'm going to basically give you what I do with antipsychotics in an acute setting in an emergency room most of the time. We talked previously about that you can use a low potency first generation antipsychotic such as Chlorpromazine mixed with some other things. You can use a high potency antipsychotic such as haloperidol mixed with some other things, and that's probably what most of people have seen in emergency rooms is the 5-250 Haldol Ativan Benadryl combination, which I'll talk about in a second. But my favorite combination is to use an atypical antipsychotic, one of the newer ones, because you also cover for mood symptoms, and they're generally a little easier to tolerate. You're going to have less acute side effects from those as well, though there are long-term side effects if you're going to use them. So I'm going to talk about 4 quick combos. I'm going to start with what I use most of the time and tell you why. So in an acutely psychotic agitated patient where I'm not 100% sure what's going on, but generally the patient seems like there's not a major medical issue going on, but I could be missing withdrawal delirium. They look a little maybe manic, a little maybe on the schizophrenic spectrum. I'm not entirely sure. But even if they are locked into one of those things, this combo covers everything, which is why I like it. And that's risperidone, Lorazepam, and diphenhydramine, or Risperdal, Ativan, and Benadryl. And in a severely psychotic patient, I'll use 3 milligrams of risperidone, 2 milligrams of Lorazepam, and 50 milligrams of diphenhydramine. That's a very sedating combination. It'll actually put most people to sleep, and they'll wake up doing a lot better. If they're not as bad, back off on your risperidone or your Lorazepam by 1 milligram. That's the other nice thing about this, is it comes in 1 milligram increments, so you can adjust pretty well. The disadvantage to this combination is that it only is really available in oral form. There are both dissolving tablets of risperidone and a liquid, which is nice in addition to the tablets, so that can make it easier to swallow literally, but there is no intermuscular version that you can immediately switch to, or no intravenous version that you can switch to if the patient won't take it. Therefore, what you do see is being very popular in ERs, largely because of that fact that you can switch back and forth between oral, intermuscular, and intravenous, is pretty much the same combo of Haldol, Ativan, and Benadryl, just swapping out Risperdal for Haldol, in which case this often gets called a 5-250 or a B52, where the 3 amigos, because the combo covers a lot of bases. 5 milligrams of haloperidol, 2 milligrams of Lorazepam, 50 milligrams of diphenhydramine. Again, oral, intravenous, intermuscular, doesn't matter. The big difference is how quickly it works. Oral takes about 45 minutes, intermuscular 15 to 30 minutes, intravenous. I don't have a ton of experience with myself because we don't have IVs in most of our patients, but in theory should kick in 5 to 10 minutes. If you need to increase from there, that you can double the haloperidol quite easily. The maximum dose of haloperidol is actually 100 milligrams, although you make somebody stiff as a board if you do that. Something I do see ERs do that I recommend against is giving what we call, sorry, had a brief clinical interruption there, but I was saying don't give Haldol by itself. And that's because you will see sometimes what we call paradoxical agitation with that, and that the side effect of haloperidol, or really all the antipsychotics, but particularly the high potency first generations, are all these muscle side effects that are short term. So you can get akathisia, which is this restlessness where the patient will get more agitated because they just can't sit still. You also can get some very scary side effects like an acute dystonic reaction where all their muscles will spasm. Of course, there are other big baddies, tardive dyskinesia long-term, or neuroleptic malignant syndrome, which is just unpredictable. But Benadryl or diphenhydramine seems to mitigate those risk factors. And the Ativan actually also lowers your risk of muscle spasms, so we like to give that combination. Together, you can keep cranking up the haloperidol if you need to. You can bump up the diphenhydramine and the Lorazepam a little bit if you need to, maybe go up to 3 milligrams of Lorazepam and maybe 100 milligrams of diphenhydramine, but I wouldn't recommend going a ton higher than that in most people, because you are going to run into over-sedation and respiratory depression and things like that. Though again, if you're in a traditional ER, maybe that doesn't scare you. But if you're in a psych ER where I am, I want to make sure that people keep breathing. I don't want to ventilate them. And I can go all the way up to very high doses of haloperidol and not worry about that happening. So the 3 amigos is a good backup combo, but you're not going to get the mood coverage that you are. Some other alternatives to think about when you really need to sedate a patient, two of the most sedating medications out there in terms of antipsychotics are the old Chlorpromazine or Thorazine. It will just knock a lot of people down. It's not a very high potency antipsychotic milligram for milligram. So you generally get 50 or 100 milligrams orally, 25 or 50 milligrams intramuscularly. You do not need to mix this with diphenhydramine because it's already pretty anticholinergic. You can mix it with Lorazepam or diazepam or your other benzodiazepine of choice pretty safely. And again, you'll get more sedation out of that. Lanzapine or Zyprexa is probably the most sedating of the newer antipsychotics that you're going to use on a regular basis. Quintiapine Seroquel is probably just as sedating, but it has a lot of alpha blocking effects where if you give a huge dose of Quintiapine Seroquel right away, the patient will get dizzy and fall down on you from orthostasis, and you don't want that. But Zyprexa you can get very high doses of, get a very strong antipsychotic effect and sedate a patient very well. I used to say if you have to have just one drug that you want to give by itself, Lanzapine is your just cover everything in terms of psychosis, mood, a lot of different conditions. Medication, you can mix it with diphenhydramine, though you don't need to because you're not going to get the extrapyramidal side effects that you will with the first generation antipsychotics or even that you would get with risperidone, but you can get some extra sedation by adding that. Orally, you generally can add Lorazepam as well, though there is a black box against using a benzodiazepine with a Lanzapine when you're using it intramuscularly, and that's due to the risk of respiratory depression. Again, we used to do that a ton, but it is black boxed and it is potentially dangerous. So I don't do it anymore. I don't use intramuscular Lorazepam with intramuscular Lanzapine. But just the Lanzapine and diphenhydramine, if you need to add it by itself, can be a pretty potent knock them out kind of drug. 10 to 20 milligrams, 20 milligrams of Lanzapine intramuscularly will definitely knock people out. So you can use that by itself if you don't like to use medication combinations. And you're not going to cause really a lot of respiratory depression. There are some weird things occasionally with the Lanzapine that have been reported in the literature in terms of it causing problems in metabolism and sudden spikes in blood glucose, but that's very rare in the short-term use. So again, for emergency, it's pretty safe. So again, some basic combinations in doses, using Thorazine between 25 and 100, depending on whether you're using that orally or intramuscularly, along with 2 milligrams of Lorazepam and 50 milligrams of diphenhydramine. No diphenhydramine with Thorazine, my apologies. Or with Haldol is your 5-250 or 10-250 if you need to be really strong. My favorite, Risperidol, 3 milligrams, Ativan 2 milligrams, Benadryl 50 milligrams. Or again, if you're looking for a really truly atypical and modern drug, use a Lanzapine 10 to 20 milligrams. All of this is for young, relatively healthy patients. If you're talking about geriatric populations, you should be using a tiny fraction. So like haloperidol, like 0.5 milligram if you're talking about geriatric populations, and try to avoid that in dementia as a whole due to the risk of increased mortality. But if the patient is acting in a dangerous way, that would increase their mortality. Anyway, you may have to use it, but just be aware in geriatric populations, you're going to use massively lower doses. So quick summary of these things. I appreciate you continuing to like, subscribe, and hopefully learn some things here. We'll continue with the next lecture on bipolar disorder next week.